So, good evening, everyone. Welcome to another discussion on breast cancer as part of the Breast Cancer Awareness Month series that we are doing. Today, we discuss how you can navigate the treatment phase of breast cancer more effectively and why it's important to make better choices during this phase, as well as stick to the protocols that are being defined for you. We are very privileged to have with us Dr. Susanta Paikaray, Senior Consultant Medical Oncology at CG Panda Cancer Hospital in Cuttack. And we've got Dr. Rajesh Bollam, Consultant Medical Oncology, Yashoda Hospital, Secunderabad. Um, Quick reminder, Patients Engage, we are an online platform for patients dealing with chronic diseases and their caregivers. They are able to share their lived experiences and information, and they can learn from each other, as well as we moderate content and curate content and interview experts on various aspects of managing a condition. Our objective really is that the better informed you are, the better decisions you will make, and it will lead to better quality of outcomes. And the other aspect really is that for you to know that you're not in this alone, and there are others in the similar situation as well, and you can learn from each other. um, you can find a whole lot of our content on the website as well as on our YouTube channels. On breast cancer specifically, we have talked on various aspects over the years, whether it's about relationships, whether it's about fitness, body image, dealing with side effects, etc. Um, Reminder also that tomorrow we are talking to two other oncologists on living well after breast cancer as well. So do join in to see what you can learn from that, and how you can manage that part better. And on Tuesday, we spoke to Dr. Meenu Walia and Dr. Shrikant Tiwari on the signs, symptoms, and risks associated with breast cancer. So again, be aware, because this is an important topic, and we do have a fairly high percentage of women who get diagnosed with breast cancer in our country, and that too at an advanced stage. Um, so, as I said, we are very privileged to have Dr. Sushant Kumar Paikaray and Dr. Rajesh Bollam with us today. And I'm Aparna Mittal. I'm the founder of Patients Engage. A couple of disclaimers. This uh, webinar is supported in public interest by Pfizer. The content is meant for information and awareness purpose only, and is not to be a substitute for medical advice. So do discuss with your doctor specific issues that you have, and you can take the inputs from this and have a discussion with your doctor. The views expressed are of the speaker, and Pfizer or the platform may not endorse the same. uh, as I said, do discuss specifically with it's not replacing a medical consultation, but you can post your questions on Zoom, Facebook, and YouTube over the next 30 minutes, and we will try and pick them up and address them. And you can reach out to us through our website, www.patientsengage.com, or any of our social media platforms. So let's get started. I think thank you once again, Dr. Sushant and Dr. Rajesh, for joining. As I said, we have talked in the last webinar on the signs, symptoms, etc., but wanted to understand what are the treatment options available for breast cancer, and how is it different at various stages. So, Dr. Sushant, if you can start on that, please.
Yeah, definitely. That we have four stages like other solid malignancies. The breast cancer also have four stages, and that stage one, stage two, stage three, stage four. And the thing is that the paradox is that that in Western countries, stage one and stage two patient was more than our country because of awareness, the cancer awareness. So our patient, we are not doing routinely for screening mammography. So our patient diagnosed late. So stage three, stage four patients are more in our country, and the cure rate. That's why mortality rate also high. And another thing I want to focus that like stage one, stage two, more than 90% cure rate. But if coming to the stage three, it is 50 to 60% cure rate, and not that approximately. And the stage four, it is around 20%. So then
Right.
coming to this is the stage wise data overall. Then in breast cancer, there is a management. As till now in our country, we are following the immunohistochemistry markers, like whether the patient is hormone receptor positive or hormone receptor negative, or HOT2 positive or HOT2 negative or triple negative. This is the three varieties we are following. And if it is hormone receptor positive, even if stage 4, the cure rate is more than 20% also. And patient may live longer as a chronic disease. So then coming to what are the treatment options available? Stage 1. So till now, if it is not triple negative, only hormone receptor positive, in our institute, we are following the surgery first, followed by adjuvant chemotherapy, or we are doing the prognostic marker. We are giving only endocrine therapy, that is hormonal therapy, or we are giving adjuvant chemotherapy. If it is stage 2 and stage 3, then mostly we are following the neoadjuvant chemotherapy. That
Right.
is in triple negative, they must need, even if stage 1, they need uh, neoadjuvant chemotherapy followed by surgery and radiation therapy if indicated, followed by sometime in neoadjuvant chemotherapy. If the patient is properly not responding to the chemotherapy, then we'll go for any additional treatment for the triple negative. But for the hormonal therapy, it is the hormone receptor positive, it is only the hormonal therapy followed by chemotherapy. The
Right.
chemotherapy followed by radiotherapy. So this is the overall treatment pattern. But there is in breast cancer, there is many things you have to consider. The age factor, also the presentation to a clinic, whether the patient performance status is good or not, whether there is any morbidity like cardiac morbidity or any other illness like diabetes. So we have to consider all the things. So if we consider in one line, if it is stage 1, stage 2, go ahead with surgery and chemotherapy. If indicated, radiation therapy. In stage 3, surgery, chemotherapy and radiation therapy. In stage 4, it is only palliative chemotherapy or hormonal therapy or targeted therapy. This is the things available. Whatever, another thing I want to give the message that in any stage, breast cancer is a good disease. We can treat better way in our country, all the type of treatment available. So all the listener should avail all the type the treatment for any stage.
Right. I think that's an important one, that, as you said, there is treatment available at various stages, and it is worth, availing of that treatment. Dr. Rajesh, one of because there are so many different types of tumors, as well as different stages, and therefore, one of the things that people often get confused in, whether it's support groups or even informal conversations, is they'll start comparing treatments, right? And then they say, but I didn't need to do this, and mine was, my chemo was before or mine was after. So to a large extent, Dr. Sushant has explained that, but if you want, if you want to address that concern or that confusion that creates in people, how would you want to explain that to from a layperson's perspective?
Yeah, it's a wonderful question because majority of my patients do ask the same thing in the clinic.
Mm,
So breast cancer is a heterogeneous disease. For all practical purpose, we can divide breast cancer into three groups: localized, locally advanced, and
right,
metastatic. If it is a localized, for all practical purpose, we do the surgery first, following which, based on the reports, we either give adjuvant chemo, hormone, or targeted therapy.
right,
And if it is a locally advanced, in order to make the tumor small, first we need to give chemotherapy, make the tumor small, excise the tumor, and then treat it with adjuvant. In an advanced disease or a metastatic disease, we usually go ahead with the chemotherapy first. So
right.
first we need to see whether the disease is localized, locally advanced, or in advanced. Accordingly, we will sequence it. This is first thing we need to know.
Mm,
And as I said, it's a heterogeneous disease. The treatment doesn't remain, the treatment varies based from person to person. For
right,
example, if the patient is a HER2 positive, he would require a targeted therapy in an adjuvant setting for a period of 1 year.
right,
Suppose if a patient is a hormone positive, she would require post definitive treatment, she would require at least 5 to 10 years of hormone therapy based on whether the nodes are positive or negative. Suppose
Mm.
if she was a triple negative, like ER, PR, HER2, all three negative, then the treatment would end like chemotherapy, surgery, and adjuvant chemo. So your treatment depends on two factors, whether it is localized, locally advanced, or metastatic. That is step one. And step two, what is your IHC status? Whether you are hormone positive, whether you are HER2 positive, or whether you are triple negative. Based on these two factors, the treatment of patient varies. I hope the
Okay.
things are
Yeah.
clear.
Thank you. Thank you. Um, Dr. Shashant, one of the things that patients really are, the first thing these days they want to understand is the role of nutrition. What should I eat during my treatment, and what can I do? Can I exercise during my treatment? So what is, your response on that? And lots of people spend so much time on thinking about what to eat, what not to eat. So, what is your advice to patients on that count and
That
their family members?
this question that many times they are asked by the patient to me in our clinic. So the thing is that I only advise in simple thing because uh, our many of our population now also they belongs to low socioeconomic status, and few of them are middle and high socioeconomic status. So it is very difficult to advise any that marketing that available that protein powder or in anything nutrition. So I simply explain them. He just take the foods which has without spices and less oil, and
Mm,
there should be fresh. It should be cooked in your home, and it should be taken freshly, not taken any stored food, or not taken anything that is available outside. So it is homemade food, fresh food, no spicy, less oily. You can take it. No
right.
contraindication for non-veg and any vegetarian diets. Another question the village people ask me, that is many myths are there, that if you take in non-veg more, then breast cancer incidence will be more, and the
Mm,
cancer will not responding to may not responding to the chemotherapy. This is the myth.
right.
That's why I explained there is no contraindication for non-veg diet. So we can take the non-veg diet, but thing is that we should not take many things spices with the non-veg diet. So if you boil and simply add a little bit salt and that is haldi also, that's enough. No,
Mm,
nothing to add anything to the non-veg. That is the problematic for the non-veg diet. Otherwise, the simple word, homemade food, fresh food, and less oil, no spice. This is the
right.
for the diet. For the exercise part, as per the we are trained about that many times it is discussed in oncology conference. We can do a mild to moderate exercise, better to avoid the fatigueness due to the chemotherapy. So
Mm,
we can advise if patient is stable and not much felt weakness, then we can advise mild to moderate exercise to avoid the chemotherapy-induced fatigueness. So this is my suggestion.
okay. Thank you, Doctor. Dr. Rajesh, the various treatment options each have their own sets of side effects. So, can you kind of talk us through the various side effects? I know most people are aware of the chemo ones, but if you can still talk about it and how best to manage them.
Yeah. So basically, as you rightly said, the side effect of the treatment depends on what therapy you give. For
Mm,
example, if you are giving a conventional chemotherapy, what we use in the regular breast cancer patients, majority of the times, the regular side effects being alopecia, that is hair fall,
mm,
vomiting sensation, and one more important thing is decrease in blood counts, because chemo doesn't know which is a normal cell, which is a cancer cell. The only thing which it knows is to kill all rapidly multiplying cells. So
mm,
as the hair is a rapidly multiplying, it can cause alopecia. As your gut mucosa is a rapidly multiplying thing, it can cause vomiting and loose motion. And most important, as the blood cells are rapidly multiplying, that can cause decrease in WBC count, with what we call it as neutropenia. So one of
right.
the important things one should be aware is, whenever you have got neutropenia and fever, we call it as febrile neutropenia. And at this point of time, you should immediately report to your doctor and take the treatment, not just take the pop up the paracetamol and not to sit at home. One of the
Mm.
important things is this, because usually patients, we lose patients, especially rather than the disease, because of the complications of chemo, that is febrile neutropenia. This one should be aware of. The
Mm.
other side effects being, for example, if you are using a targeted therapy, either it could be a HER2 targeted therapy, one of the side effects being a cardiac related dysfunction, or even in the breast cancer treatment, for one of the group of drugs, there's a cardiac related dysfunction. Hence, we advise these patients every 4 cycles, if they are taking HER2 targeted therapies, every 4 cycles they should undergo the 2D echo. And the third group of agents which we use in a breast cancer would be hormonal agents. Even though the incidence of side effects with these hormonal agents are little less, but they can be troublesome, especially in the younger ones, because these artificially induce menopause kind of symptoms, and the ladies come with complaints of hot flushes, vaginal dryness, dyspareunia, multiple things.
Correct.
These are also should be kept in mind, especially whenever you are keeping a young woman on a hormonal therapy. This is with respect to the systemic therapy complications. And with respect to the local therapy complications, like for example, radiation you are giving, it can cause dryness of the skin, redness, rash, which are temporary and can be ameliorated with using some of the topical therapies.
Mm.
Yeah.
Okay. And there's, I think, also discoloration of,
Yeah. So we call it as radiation dermatitis. We can prevent it by using any emollients or normal substances which we can try to control it. Yeah.
Right. Okay. Um, Dr. Sushant, in terms of psychological and emotional support that breast cancer survivors need, I think there is now greater uh, awareness that it is not just a physical disease, but it also affects the patient or the survivor emotionally. What is the kind of support that they should seek, and what is available as support in hospitals today?
Yeah. Actually, whenever patient come to clinic, we should see the age. What is the age of the patient? Because it is more psychologically impact on the younger patient, that those are diagnosed less than 50 or 40s. Even if nowadays, due to the lifestyle changes, it can be diagnosed less than 30 also. Few patients are less than 30. One of my patient came to me that just to be married, so that diagnosed with breast cancer. Luckily, he is hormone receptor positive. So that counseling, that you have to counsel about fertility preservation, because we are giving that chemotherapy which will affect the germ cell also.
Right.
Whatever Dr. Rajesh told, that it will affect the rapidly growing cell, the germ cell included in this. So it may affect fertility in younger patient. So we have to counsel that part also before starting the chemotherapy. And we have to add some protecting some endocrine like therapy, that GNS analog, so that we'll arrest that germ cells so that it will not divide and we will escape from the chemotherapy drug killing. Or in any case, we can preserve the oocyte. This is the one part if the younger patient came to us, because that also affect in near future psychologically. Because she may cure, but she will not get the child. So this is the one part. Second part is you should involve always the family members. That those are the educated patients, they know that about the cancer. But the village population, they still thought that it is like a germ. It can spread person to person. If you sharing the plates with the cancer patient, the cancer may happen to them. So we have to counseling family member also. It is not a communicable disease. So it is a non-communicable disease. So you can share and all the thing, we can support our patient, our family member during the crisis period. So that this is the most important, it will not spread. So that family support will that available.
Will be available.
Exactly. Because this is the myth. the majority of population now also thought that it is a communicable disease.
Right.
So this is
Right.
the thing you have to clear first.
Hmm.
Then during treatment also needs family support. Another thing is cancer patient also needs some attendant, the family member support to come to hospital and to day that investigation, all the things that should be taken care of. So we have to count along with the psychological support to the patient, also to the family member, and to discuss all the things that about how much the lady needs the family support. That's
Right.
most important. Another thing is if another thing is body image problems, because
Hmm.
of we are going to taken that breast can breast that maybe MRM modified radical mastectomy. But nowadays, if it is locally advanced also, and there is if you patient is responding to chemotherapy well, we can go ahead with breast conservative surgery also. So breast
Hmm.
conservative surgery also available. Many of times, different types of sentinel lymph node biopsy, and we are selectively remove the lymph nodes. So nowadays the plastic surgery also available. So this type of thing, if we get that type of treatment in our hospital, then that also taken care of the body image problem. If we go for the breast that breast conservative therapy, then it will taken care of. Another, if you go for anyhow, if there is a contraindication for the breast conservative surgery, then we have used some prosthesis, or we can give this maximum psychological support that we can told that even if there is body image problem, but it will give to you the survival benefit. So we can give some positive idea for that. After treatment, I think many of times there is occupational problem. If the lady is a service holder, then it may be so that we can support socially, and this any many occupational support by the other social worker. If it is
Right.
helpful, then we can give that.
Right.
Then after that, if it is ladies old age, then we have to support. We have to support that by the family members. That many of times the son was stay outside, so we need other social support like other NGO support to support them do all this in the like a family member. So this is the issues with breast patient. Likewise, as per the age.
Right. Thank you. Um, Dr. Rajesh, one of the things we've seen, and maybe you have a view whether it's getting better or not. One of the things we found was that the follow-up routines that patients follow after the intensive period is over is not, they're not quite clear. So some of them are very diligent about going back as per what their doctor says, but others are not, right? So what is typically the follow-up routine that is suggested? And we can look at those whose cancer is already in remission, but those who's not in remission as well.
Yeah. So one good question, because majority of the times patient do follow the advices of the doctor when they're actively on treatment. But the
Mm,
moment the treatment is over, majority of the times, because as the hormonal therapy is for a long period of time, 5 to 10 years sometimes, patient tend to miss the tablets, patient tend to miss the follow-ups. Sometimes they might stop the therapy by themselves and come up with the relapses. Hence, it is
mm,
very important. Taking the treatment and post-treatment surveillance both have an equally important role, because during those surveillance, we usually clinically examine them and check whether there are any early signs of relapse. If so,
right.
in early phases, we can catch it and then treat accordingly. Usually, patients, suppose if the patient's disease is in remission, initially for an year, we call them once in a 3 months. Once in 3 months, we do the clinical examination, and if it is normal for an year, so later we can call them in the second year, we can call them once in 6 months, and later post 2 years, we can call them once in a year. It all depends on the disease biology as well. Suppose, for example, if somebody is a hormone positive, usually the disease is indolent, and in these kind of patients, we can be little relaxed on the follow-up schedule. Like even if you call for post 1 2 years, even if you call for once in a year, that should be fine. Suppose if a patient is a HER2 positive or a triple negative, these are the kind of patients who come up with relapses more. So these
Mm,
should have little stringent follow-up schedules. At least for next 2 to 3 years, they should be asked for once in 3 months, and we need to tell the importance of regular follow-up. And most importantly, we need to educate them. What are the signs of early relapse? What are the things one should be aware of? And if these things are noted, should come immediately, even without waiting for the next appointment schedule.
mm,
That is one important thing. And we need to send them regularly messages regarding the importance of taking a daily pill, because majority of them tend to skip. So this is for the patients who have completed their therapy and are on follow-up. For
mm.
patients who are on therapy, like for example, if a patient is a metastatic disease, stage 4 disease, who are on continuous palliative therapy, for them the goal is to follow up them 1 day prior to every next cycle. Like there
Right.
could be once in 3 weeks, or it could be once in a week. Accordingly, we need to follow them.
So on that, just a follow-up question on that, when they come for follow-up once in 3 months, etc., those who are not on active therapy, um, are there any guidelines which say that at a frequency they need to do, say, the DEXA scan because of some of these treatments have osteoporotic effects, right? Or is there a way, is there again a guideline which says that you need to check for lymphedema for patients and so on? So what are the kind of things that are looked at apart from the tumor itself, whether there's been whether the PET scan, which it will indicate whether the tumor is back, or the clinical breast exam, but what are the other scans or testing that is recommended?
Yeah, it's a wonderful question, because majority of the times post treatment, we should not only concentrate on the tumor but also the other things, as you
Mm,
said, especially in an elderly woman who are on hormone therapy, like for example, aromatase inhibitors. These are the kind of patients, they do have osteoporosis, and we usually, even though guidelines recommend us to do a DEXA scan, but in general, majority of them, either because of non-affordability or lack of availability, we keep them on a prophylactic bone strengthening drugs. For example, either we can keep them on once in 3 weekly bisphosphonates, or once a week oral bisphosphonates. That is one.
right.
And if the baseline Z score is low, meaning the baseline, the tendency of the bone to have an osteoporosis is high, maybe an
Mm,
yearly DEXA we can recommend. And in the follow-up, usually majority of the times the corporate practice is to do PET scan, but ideally not recommended. Like for example, if a clinical breast examination, if your mammo is normal, an yearly mammo, if it is normal, initially 6 months later, one yearly mammo is normal, then we might even omit the PET scan. But if your clinical examination or your basic blood workup shows some abnormality, to confirm is there any relapse, you can get a PET scan done. So to summarize, one is clinical examination to see is there any early signs of relapse. Second is, as you rightly said, DEXA scan for especially an elderly woman who are on AI. Third is to check an imaging. And most importantly, not only these three, the complications of the anticipated complications of the drug we use, because majority of the times these AIs can cause some metabolic complications like dyslipidemia,
mm,
diabetes and all, because we
right.
need to comprehensively look at the patient, not just the patient and patient disease, but also the expected side effects of the drugs. Because
Right.
sometimes when the patient is on bone modifying agents, they can have some renal dysfunction, or they can have the side effects which is with respect to the teeth, what we call as osteonecrosis of jaw. So
Right.
we need to look, one is disease aspect, second is whether they are taking the drug properly or not, third, are they having any side effects secondary to the drug or not? These are the three aspects which one should look for in the
Thank you.
follow.
Thank you so much. Dr. Sushant, one of the things that really worries people is, when am I getting a relapse, or, is my cancer going to come back? So one of the things that they're always looking at is what can I do to prevent it from coming back? Is there anything that can be done? And if not, what's your advice? And if yes, then what can they do?
The thing is that whenever patient asks this question during diagnosis or after the treatment, just today also asked one of my patient that, sir, our treatment completed. do we need any vitamins to prevent
Mm.
relapse? I told them single line that that's why we are all gave chemotherapy that is called adjuvant chemotherapy. That is
Mm.
the aim of the adjuvant chemotherapy to prevent the relapse. So, what is adjuvant chemotherapy? Means whenever we'll dissect out or by surgically, we remove all the visible cancer cells, imaging wise, or by whatever the surgeon failed during surgery, they remove. It is R0 resection. Then after that, anything we are giving that is called adjuvant chemotherapy. That motto is in breast cancer that initially, whenever breast cancer detected, that is 1900th century, the main treatment is the surgery. But
Right.
after that, the doctors observed that even if after adequate surgery also, there is a relapse. Why there is a
Mm.
relapse? Then breast cancer considered as a systemic disease. So we are giving chemotherapy to prevent the relapse. So
Right.
this is the question, first question, and the answer to the not having relapse is the chemo adjuvant. They need definitely need adjuvant chemotherapy or adjuvant hormonal therapy or adjuvant targeted therapy as per the immunohistochemistry markers. This is
Right.
the thing. Then another thing, even if they received the adjuvant treatment, then also there is a chance of relapse. That is happens as per the staging.
Mm.
And what are the hormonal receptor status? If
Mm.
hormonal receptor negative and HER2 new also negative, that is called triple negative, there is a
Right.
relapse within 3 years. And if the patient have stage, as per the stage increase, the relapse rate increase, even if we are receiving the adjuvant chemotherapy. Then why you need adjuvant needs? But if you receive the adjuvant treatment, then there the relapse rate is less. So there is a two factor. One is stage, another is whether the patient received timely adjuvant treatment or not. This is the
Right.
two factor deciding the relapse rate. So there is only the option is you have to take all the treatment as per the protocol so that we can decrease the chance of relapse. And this is the only way to prevent the relapse. We should follow the whatever the doctor's advice or the oncologist advice to the patient so that whatever you asked the previous question that the patient lost follow-up, the patient thought that after surgery, treatment was completed and
Right.
not needed any form of treatment after the surgery. So this
Mm.
is the myth with the all many of the patients. So I request all the patient that you have to follow the doctor's advice. If doctor advice to follow up after the months, yeah, after the days, so they have to come to us or the oncologist so that we'll tell them ki, whether your treatment completed or not. Like in hormone receptor positive, it is the 5 to 10 years of treatment. Even if your
Right.
chemotherapy, radiation therapy, and the mm, surgery was completed, that after that also the treatment continues. If it is perimenopausal or premenopausal, it is more 10 years, or if it is menopausal, it is 5 years. So you
Right.
need all the things. Even if triple negative, there is no treatment further. But after the neoadjuvant chemotherapy, if there is a residual treatment, residual disease, then we need 1 year of capacitive treatment, that is oral chemotherapy. So all the things patients should add and that advised so that we have to adequately counsel and we have to, as a doctor's, my duty, have to give adequate time to patient to understand all the things. Many of time we have many less educated patient who are coming from the village. They don't know about what is the cancer like a educated woman. So we have to focus, we have to understand how much patient can understand from us,
Right.
from us. So this is the things we have to inform. So even if the 3 monthly follow-up, why we advise, because we detect the early relapse. So that
Mm.
even if you cannot cure the patient completely after relapse, but we can give early treatment so that the quality of life will maintain even if with treatment.
Right. Dr. Rajesh, one final question. Does testing help in assessing the risk of recurrence?
Yeah, wonderful question, because majority of us patients these days, at least more than the patients who attend us would ask us regarding the genetic testing.
Mm.
And they would come up with a question like, my grandmother had a cancer, my mother had a cancer, they were no more now. Can I
Mm.
undergo the whole body testing? Can I
Mm.
undergo whole body genetic testing and all? So first we need to understand the concept. Whenever a patient has a breast cancer, all, to be very frank, all breast cancers are not due to genetic.
Right.
If you see the stats, it's less than 10%, which is a genetic thing. So
Mm.
first thing, there are some indications to get a genetic testing. Like for example, if you are a triple negative breast cancer, if you've got a breast cancer in a younger age, or if you've got bilateral breast cancers, or if you've got family history, like more than two people affected with the breast cancer, there are some certain indications wherein which the genetic testing is required. That is step number one.
Mm.
Step two, suppose whenever the genetic testing is indicated, first you need to do it to the patient and see if there is any gene which is abnormal, yes or no. So
Right.
if some abnormality is found in the patient, we call him as an index patient. And if the gene is present in the patient, that gene has to be tested in the family members. This is how the genetic testing goes, because majority of the times patient do come with no previous history of their parents. They just know that their grandfather, their grandmother, or some family
Somebody
members
had
had a
cancer.
cancer, but what
Mm.
genetic mutation was there? So because if you and me also go and get tested, those genes would be present. Mere presence of the genes doesn't make any difference. Look, we need to see whether the gene is a pathogenic, yes or no, and whether it is present in the index patient or not. Like that is
Right.
first thing. So suppose if someone has a gene mutation found in the index patient and we have sequenced it, and if the same gene is present in the kith and kin or the family members or the first cousins, then they need to get it tested for the same. Usually the genetic test, what we usually recommend is, if the patient has financial constraints, we can get just BRCA1 and BRCA2. If there are no financial constraints and they can undergo, there's something called as hereditary cancer gene panel, where in which the most commonly mutated genes can be tested for, like P53, PALB2, CHEK2. They have got list of around 10 to 12. But for a layman's information thing, at least the most common ones one should look is BRCA1 and BRCA2. If at least
Right.
these things can be taken care of, I think one should, if these are present, then they should approach their doctor to find more information about how to reduce the risk and all.
Right. Okay. Thank you so much. I think we don't have any other questions at this stage. Any final comments, Dr. Shashant? We'll just get final comments from both of you.
And that my message is that breast cancer, the breast is the external organ. We can detect as early as possible, even if you self-palpate, then also we can detect. So that's why it's the beautiful, and it is the cure rate is also very high if it is detected stage 1, stage 2. So my advice to all the women that you should self palpate, and you can go ahead with, if your age is more than 40, go ahead with screening mammography. Even if it is not palpable, it was detected early, even if less than 1 centimeter size also. So that we have till the cure rate may be the 99 to 100% also, even if you detected 0.5 or 1 centimeter mass. So
Right.
it is can be detected by yourself or by the screening mammography. So you should take the treatment as early as possible to get the cure.
Thank you. Dr. Rajesh?
Yeah, I do agree with Dr. Sushanta. One important thing, out of all the treatment innovations and any drug which have been come into the breast cancer armamentarium, the maximum benefit with which single intervention we can reduce the mortality is screening. And screening is way to go. And everyone should at least advocate, at least tell their kith and kin and the family members, their mothers or their wives or their relatives, that as a part of you can give them at least the screening thing, like, because you should make it mandatory on a particular day, be it be every first of Jan, or it's a birthday date or an anniversary. You should make sure that you have to undergo screening at least for the preventable cancers, wherein which we have something to prevent and then cure, like cervical cancer, breast cancer. We have got few cancers wherein which the screening is there and very much preventable.
Thank you. Thank you so much. And thank you to our audience as well. Once again, I think Dr. Sushant and Dr. Rajesh, you took a lot of time to explain very well to our audience, and I'm sure it's very useful for them. And we do hope that people will take into account what these two doctors have said, and you will uh, understand the role of different treatment options, as well as follow through on the not just the treatment as well as the follow up. And as Dr. Shashank said that, and both Dr. Rajesh have said that screening is important. So I think that continues to be a message that we need to continue to highlight. So thank you once again, and thank you to our audience as well.